Okay. Crystalline, you're sharing? Yeah. All right. My name is Dr. Vindu Verghese. I run Oyamed. I have Crystalline with me today to do the sexual history and how to take the sexual history properly, because that's something most of the doctors struggle with. So before I begin, I want to acknowledge the traditional owners of the land and pay respect to the elders past, present, and emerging. So now I think most of you would have heard about Crystalline at some stage. I will leave it to her to run the session because I trust her.
Thank you so much, Dr. Venu. Kia ora koutou. I'm Chrislyn. I'm a medical doctor. I'm part counselor, and I'm doing this especially for Oyamed today. And this session is not particularly based on theoretical knowledge, rather than clinical skills and real practical stuff that's going to help you with sexual history taking. Just a little bit about myself. It's not showing, right?
No, I can't see.
Oh, yeah. Got it.
There we go.
Oh, yeah. So that's me. A little background about me. I live in New Zealand, and I'm a registered alcohol and drug counselor, and I'm also a registered health improvement practitioner. So what that helps me is to understand, I guess, another perspective of health and well-being, which is behavioral interventions and behavioral health. I want to focus on sexual history taking and why I think this is really important, because unless you do it enough, I think you might not know what you don't know. And that's what I was coming to here. You might think you know all the theory, and you might think this is pretty straightforward. And when it comes to the exams and the OSCEs, you might think, why is it not working? And then you go down the spiral of, you know what, I don't know as much as I know. So I guess what I want to establish in this whole presentation is to make sure you have the confidence of the beginner with all the knowledge. And today, what I'm going to supplement is the practical stuff, the common pitfalls candidates usually face because of lack of practice, actually. Coming to the next part. So, what we cover in the next hour is, why is this a hot topic? I guess focusing on the values, and this is what was going to help you individually as such. Then I'm going to come back to the basics. So, core framework of sexual history taking, counseling and management, and high yield scenarios. I do have role plays. So, there is a script. If any of you are keen and you just want to use the script, I would be happy to do it with you as a patient, and the script of the doctor is in there for you to look at. Whatever it is. So I have two. If you have anyone who wants to volunteer, you could do that. Otherwise, we'll leave that for the last. Coming to the next one, the first one. Why is this a hot topic? Okay, so the first thing is there's too many learning outcomes that's actually assessed just with sexual history taking and sexual well-being counseling. First one, the most important one, is to judge bias in healthcare professionals. So what this actually does is it's by just this one question, it's actually looking at your overall behavior and health attitude towards a particular patient who you would be commonly encountering in Australia. Just looking at the participants, we still have 9, is it? Okay. Yeah. Just if you have any questions, I forgot to signpost it, please put it up in the chat box as we go, and we'll answer them as we go as well. Okay, coming back to bias. So that's the main stuff that comes out. And that's really goal for AMC, because with that, they are really easily able to gauge a candidate's overall attitude. So that's one. And what I'm going to come towards the next, in the next slide is the beliefs, attitudes, and behavior. So just park this thought for a moment. The next one is testing your communication skills. How do you navigate uncomfortable conversations? How do you navigate tricky questions? And yeah, so that's another one. Then the third one is your counseling skills. So how are you able to navigate a counseling situation, which is actually going to be a very common situation you might encounter in your day-to-day practice. And the fourth one is ability to manage a public health issue and not make it worse. Most of the times, if you read literature, you will find out that healthcare bias towards particular population groups, and we'll come to that, is going to actually make things worse for that population group, increase inequities, and in turn cause an increased healthcare burden. So very important stuff to consider this. And what else, like a better question than this? That's why it keeps getting repeated, and it's not particularly to cause any discomfort rather than to check how are you overall in these things, right? Okay, coming back to the next one, we'll focus a little bit about values that can help and values that won't. Okay, so from a counseling approach, right, we all have these core beliefs and our own perceptions, and it could come from culture, it can come from reading, it can come from the videos we watch, and these in turn infiltrate our thoughts, right? Our thoughts infiltrate our feelings, and then together these come up in our sessions and our consultations as a health practitioner. So I guess the most important thing is you wouldn't know what you're thinking and you would behave a particular way because you didn't know it was part of how you felt about things. So coming back to the values, what values are going to help you hack the station? First one is sexual well-being is important, and it is the basic necessities as important as food, shelter, and clothing, right? Um, so it's firstly it's important, and second thing it's personal. So it's very important to address both of these issues when you're approaching the station. And the opposite of that is avoidance. It's not important. So that's going to make things worse for you if you did feel that, you know what, it's not as important to you again. So remember, it might not be as important to you, but if you avoid this topic altogether, it's actually going to be perceived as you're biased towards particular taboos and stigmas and discriminations. That's going to affect your clinical judgment. And you can see it on your face, there's not much to do. It's as important as MI or DM. So you might not see a lot of heart attacks in your GP practice, but you will see sexually transmitted infections and uncomfortable conversations. So it's really important to have, yeah, it's very important. Coming back to the next one, impartiality. Um, I guess this is a one that kind of makes candidates um, look bad. First one is people have choices, right? And even if the choices are a bad choice according to you, um, it is it isn't fair to the patient. So it is uncomfortable. Patient is coming in with guilt. Patient's coming with a lot of discomfort. And now, if you are going to ask and portray your bias about, you know what, this was a bad choice, you probably knew it, and it's going to look in your face or through your consults, it's going to be a really big pitfall. And this doesn't come illicitly. This is a subconscious bias that you need to be aware of. And if you're asking, I'll give you an example of this. There's this patient who comes in, 25-year-old, recurrent STIs, penile discharge and stuff. And now you're looking at him as, oh, okay, how long ago was that? Okay, how many partners? And then you're asking all the risk questions without actually listening. You're just ticking your boxes and asking the risk. I guess that's going to subconsciously, you're thinking about, I have to take and find out all the other risks. However, in reality, what it does is, oh, you also use IV. Oh, you also have multiple partners. Oh, you also use alcohol and drugs. And now this is not going to look good. And that's actually going to be a pitfall. And it could be asked properly. I guess the more aware you are that this could be impartial, it could be a partial response to particular risky behavior. I guess that's the only way you can actually work it out. So you should be comfortable and not focus on risk as the main priority. The patient is, okay? And then the opposite of that, like that's what I said, STI, high risk, mental health challenges, all those things would come in together. And if you're thinking of all those things as a whole package for one particular individual, that's going to affect you. Next one is solutions focused, okay? Focus on the issues and concerns. Another pitfall for candidates is you're not listening. The role player is saying something and you're cutting them off by, asking the next valid question according to your perspective, and that's going to help you with your diagnosis. Remember, this was a personal situation. So if you're not listening and they don't feel validated, it's going to affect your performance. Next one is unconditional compassion and empathy. So remember again, and this is more for real life rather than OSCE situation. A lot of guilt feelings, lot of it could come with, partner issues. It could come with violence. It could come with alcohol and drug use, and there's lots of guilt and stuff going in the background there. So I think it's really important to highlight this particular compassion and empathy. So I don't use the word empathy here because if you use just empathy, and words could mean empathy, and that's why I say compassion along with empathy. So just be mindful of that. And the opposite of that is discrimination, which is, you're kind of crucifying the person for each and every risk that you find out. And that could feel horrible for the patient. Um, the other one I'd like to bring in was a trauma informed lens. Most of the times when we look at sexual well-being, we're not thinking about the social situation, financial situation of the patient, right? Um, we don't in general consult most of the times, but I'm thinking it's really important to ask, especially if you have a sex worker coming in, if you have someone who's having violence or a refugee background, and that's something that they're presenting with, and you're kind of a little bit concerned about those kind of things impacting treatment as well. So you want to look at those things, and also this I'll park this for risk and safety checks later on. Um, and then you have belief. Oh yeah, you can live your best possible life. So don't assume that the treatment would not be done or the test would not be completed. Just assume that people would make their choices and live their best possible life, and that's going to help you. That approach is going to help you with all stations, but I guess this one in particular as well. Now, something that you really need to be mindful for is awkwardness and discomfort, and that could come from your own personal and cultural biases. I guess we don't use the words like penis and vagina in our day-to-day conversations, and not using it enough is going to make you feel awkward because you've said it for the first time in a very long time. Um, Even our medical diagnosis, we have a few words, but they always come in clusters. You don't use words like sex with penis, sex with vagina. It's very I guess it's not usual to use these things. So your own discomfort is going to be your pitfall because you'll use it for the first time in EMC and it'll sound weird to yourself. It's not the word itself, it's the sounding back when you speak it loudly. So I guess unless you're a sexual health practitioner, it won't come every day. You won't see this every day. You won't talk about this every day, and that'll be your pitfall. So just remember these things when you're doing this. I guess the only way to tackle all of these is the role plays, and that's why I want to volunteer. I want you to volunteer, and if you have any issues and you want to bring it up, look, this is a safe space. You don't want to use these issues that can come up for you in the exam. You don't want it to come up on the exam day. You want it to come up beforehand. So yeah, just leave anxiety for the last day. Just prepare for all these kind of things. Okay, coming back to the next one. So what we'll cover today next is the sexual history taking and the counseling. And if we have time, we're doing good for time. So we could go through some cases as well, high topics as well. Okay, um, the consult framework. Now in AMC clinical examinations, we have domains, key domains assessed in each OSCE. Now, history could be your key domain, or counseling and management could be your key domain. Uh, with this particular topic, we have 3 minute history, we have 4 minute history, we have 6 minute history. All of them do come with counseling. So none of them come without any counseling or management. They always come with a 1 minute counseling or 1 minute management even. So very important to know all the varieties and how you can squeeze those things in. Because if you prepare a really good history taking, let's say I give you a format and it's like 8 minutes, and you're trying to squeeze it in with the 3 minute time, it's not going to work. You will get pointers within your STEM that's going to give you a lot more of the main framework stuff, and you'll need to refocus. However, the most important ones is the consent and confidentiality statement. So these two things are really, really important for every personal kind of question for mental health as well as for sexual health and breast examination as well. So firstly is the consent. I'll go through each one of this in detail as we do the role plays as well. Second one is normalize the conversation. As soon as you do your opening statement, the role player is going to act, okay, again, act in this OSCE situation, they're going to act a bit uncomfortable. That's your cue. What are you going to say? That's your normalization sentence. So what are you going to say that's actually going to get the role player to feel a bit more comfortable about this whole thing? And the best way to do it is to normalize this conversation. How you do it, what words you use. We have a script, and then you can modify it as you go. Again, I just want to highlight here, you have scripts, you have lots of stuff that you can use. You need to do it enough and make sure you're kind of using it as like it's like riding a bike. You don't have to think about these things, and that's going to be natural sounding, and that's going to remove all the biases that you have and showcase your knowledge. Next one is gender identity and pronouns, and this one's important in certain contexts, especially if you have like FSF, which is female who has sex with female. These words are not used anymore. However, when you're studying with OSCEs, you kind of use these lingos, FSF, MSM. So I'm just bringing it up there. Pronouns, these identity pronouns, so like you want to use he, she, or male, female, all those things are really important. Sometimes it's it and they, them. So very important to consider those things if that's important to the patient when you address them. The next one is relationship status and, stable, unstable. I'll come back to all these. And then you go to symptoms and red flags. So did you realize we don't deep dive directly into the history and presenting complaints? We just do a little bit of rapport building initially compared to other conversations. Then you do the framework of sexual health. So you ask in-depth questions about partner, practice, protection, STRs, and pregnancy. And the last stuff is your safety questions. So risk, again, looking at the trauma-informed lens, you're looking at sociocultural stuff. The sex worker is coming to you. Are they being abused as well? So you need to ask all these questions and make sure there's no risk involved when you're working with patients. So when you're doing the 3-minute, again, rapport building is like 1 minute. You don't spend more time on that. And then you do a focused history for 2 minutes. Regardless of everything, ICE is a must. So even if it's 3 minutes, what do you think is going on? Is there something that is on your mind? Is there any other concerns? Very quick, even if it's 10 seconds, you need to do ICE, okay? 4-minute history, you focus on rapport for a minute, and then you focus on what the key issues are, okay? And again, ICE is really important. That's why I put in a few things that you don't need to ask in. And all these will change. For example, main pregnancy risk is out of the way. So things will change as and when you go. And I guess you need to really know everything, and then you can flex according to the stuff. Now, gynae Ps are different. When you're having the 5 Ps of gynae, that's the period and pregnancy and what did I write here? Partner, PAP, pill. So these are the gynae ones, and these are the sexual health ones. So don't get confused about these things. Mnemonics are good, but if you yourself are getting confused, then maybe find another way around it. Okay, and
question. So for the pronoun bit, so normally in the clinic, I would ask, what would you like me to call you? And whatever the patient says, I'm fine with it. Do I have to ask, would you like, what is your gender identity? Is a he, she? How would you ask that in real life?
So that's a really good question, and I guess everyone has that same thing in their mind, and nobody asks it enough. I did a rainbow session in once a few months ago. The guy told me, you look at them, you see if they're uncomfortable, and you see. I guess you see the subtle cues. For example, someone's done their eyebrows really well. You comment on their eyebrow and you say, "Wow, beautiful eyebrows." I see the gender on file as male. Do you have another pronoun? Something like that. That's what I would use in reality. However, in AMC or skis, I think the most important cue would be the dressing. So you would see a particular dressing sense, and you would see a few cues that can help you understand if they're transgender. Now, our pronouns are more important if they're transgender. So I would highlight that. If you do sense someone is transgender, or if the STEM says transgender, very, very important to rainbow community who identify as transgender, because this is the first step towards their identity and transition. So if you take that away from them, everything else doesn't make sense, because the whole transition is a few years, right? So if you're taking away the pronoun, that's their first step towards decision making. That's going to be really hurtful for that community. So for example, if you're saying uh, a person who's dressed appropriately as conventional female, and just talking about sexual history. I don't think it's really important unless you do suspect some bisexual or queer personalities there. Again, use your judgment, read the room. If if things are really friendly, the atmosphere is not working out, you feel like there's no rapport, just go in. I'm Chrislyn. I identify as female, and my pronouns are she and her. This is something I actually asked the rainbow community. What do you identify as? That's it.
And you just ask straight up, what would you like me to call you? And whatever they tell me, and I stick with it.
Super.
Except when the stem that says they, them.
Say them. That too. Pick up the cues. Again, don't
Love that.
waste your time on this. This is not as important, right? Again, all of this in 1 minute. So you really don't have time. That's where your script comes into play. So coming back to the script, um, look, I have put in 2 slides here about the 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 stuff. So, for example, in consent, I'm going to ask some sensitive questions that I ask all my patients. Everything is confidential.
Mm.
Is that going to be okay? And then you go back, right? Then you ask these questions and you normalize it. If they're saying okay, oh okay, they'll be like, you know what, these I ask these to all my patients, and these really help me understand how I can care for you properly. That's it. And you explaining why you need to ask something that's confidential, and that's going to help. And that's where you're going with your empathy and your approach as well. So two things, you're showing your bias, and all you're normalizing it, plus you're kind of making sure the patient's comfortable, and at the same time you're kind of handling the bias people have in healthcare and showing that you're really proactive about these things. We did do gender, so I won't spend much time there. The next one is the relationship status, and there's so many versions to do this. Again, you're seeing a 50s heterosexual kind of a man. You don't have to ask much details. You just go into, are you currently in a relationship? And okay, do you have a stable partner? Okay, and if they
What
ask
is
for,
stable?
again, so the stable definition. So they say, yeah. Now you go into the deep dive. Okay, did you have any other partners? That's it. And
I
then when they say
usually
yes,
ask, do you have one or more than one partner?
hmm
That gets it going
that
because
gets
then
you.
I've asked
That's
it
a
over.
really good one. Yeah, one or more. That's my second one. So partners, one or more. Some people might find that offensive. So really read the room again. You are not going to be asking a 80-year-old female, are you having more than one partner? I mean, you could if they're having a rash or an ulcer, but really read the room, see the symptoms. It's going to give you a lot. Okay. Okay. Being neutral, and that will come only with practice. Are your partners men, women, or both? Now, with a transgender, it gets a bit tricky. So, you're seeing a transgender and you're seeing men, women, or both. Again, the first question, men and women, does not fit the criteria with transgender. So, that's where you ask us the parallel question. Do you have partners who have a penis, vagina, or both? That really simplifies everything, and you don't have to overthink it, right? And then you have, what types of sexual contact do you have? Anal, vaginal, oral, and then that's it. You name it, and they can select or all, whatever it is, right? Um, and then the condom question, right? I don't know why we ask it anymore because we still do STI screening for everyone. The most important thing is ask it anyway because it's like a checkbox for contraception and stuff.
Mhm.
Do you use condoms every time? That gets you all the
And
answers. They
also
don't use
mouth
it.
guard,
And yeah,
mouth
so
them. I always ask they use some of
yeah,
them.
yeah. So if it's a female, and if you're using dental dams or you're not using dental dams, and you're using toys and all those questions as well. So in terms of type of sex, I think it will be really important. You have to gauge the first question, and then you go back to the second and the third and the fourth, and that's going to help you identify your cluster as well, and also your parallel syndromes. I'll come to that again in a few moments. Red flag questions, I guess that is a pitfall as well, because although you're kind of handling this whole discomfort, you often forget the red flag stuff. So let's say there was, um, I don't know, you've not had any risk before, and now you're doing this, and you find a lot of risk. Then you need to ask in the basic stuff that's going to point towards the infection. So rash, pain, fever, vaginal discharge. Again, these will all depend based on your chief complaint. So obviously we're doing chief complaints first, so we're not going to kind of do yeah, this is the just general stuff for history taking for no symptom, right? And then you have your ones with the symptoms. um we would go into this one. Yep. So the red flag continued. And then the safety question about not feeling safe. And then again, this will be most important if you're having a sex worker. If you're having an MSM or someone who's using, it's called pool parties. Yeah, someone with pool parties. That was a really common thing back in the day. I don't know if it's still on, but you use pills and you have pools and you have a spa party kind of a thing where you're having a lot of alcohol and a lot of drugs and a lot of sex. And these are kind of a weekend thing in the rainbow communities. So it's kind of a lifestyle. However, you really need to ask about this because this will come into play when you're asking about doxy, PEP, and PrEP stuff. Again, not forgetting the basics, your past medical, surgical. I think the most important thing with STI counseling would be specific stuff. You have penicillin allergies. This is going to help you with this. Is there a chance you could be pregnant if you have to give like doxycycline? You'll have to change it. Vaccination history. So going back into Gardasil for females and also for males for warts, we kind of forget it, when you're doing males because you think, oh, it's only cervical screening. However, Gardasil helps with warts, and it's really important men receive it as well. And then you go back to monkeypox if you have an MSM as well. Yeah, so that's the vaccination, allergies.
For AMC wise, we still need to ask if the patient on pre-exposure prophylaxis and the last time when they had an unprotected
Yes,
sexual intercourse, because we still have to give the post-exposure prophylaxis if within 72 hours.
correct. That's another slide as well. So when you're doing the sexual encounters and those things that hopefully that should come up when was the last sexual encounter as well. That they're worried about. And also, when you're really highlighting the concern, it would be an opening statement. I had unprotected intercourse and now I'm worried. And then you go into those stuff. When you're going into STI screen, very important to consider the pre-lab counseling, which is the pre-HIV counseling. So don't forget about that stuff. And then when you're talking about STI specific screens, don't forget your blood stuff and your general stuff that's going to help you with decision making, like, LFTs and your complete blood count. So again, don't just think STI focus, think the whole health. When you're going to 4 hours, when you're having the referral and all these things, again, these are all going to be gone in detail, okay? Okay, so we do the role play next. I don't know if it's really, really small, is it?
Okay, so there is kind of an icon on your screen because you're sharing all of the slides together.
Um,
Um,
I'm on
that if you
Canva. I
press
think
that, you will
that's
get
the
the full thing.
reason.
Yeah, that
Okay,
one. It's the full
I'll
screen
just,
one. Or the bottom one. Can you see the two arrows at the bottom?
yep.
That going up like that? Ah, that one. That
Oh,
should
yeah.
get full screen. Check
Okay.
and see if you can click that.
Mm.
Up. No, it's not coming. I can't see it. But there's a
Do we
way to
have
make it.
any, do we have any volunteers, by the way?
Would anyone like to do the role play? This is such a good opportunity.
You just have to literally read the stuff in blue and see how you feel when you say these things.
Anyone?
Doc, I want to try.
Oh,
Go
good.
ahead. Give it a go. I'm happy to see. All right. You have a volunteer.
Thank you so much, Doctor. I didn't get your name. I can't see actually when I'm.
No,
Uh,
Doctor. Yeah.
yeah, Dr. AVG, is it?
Yeah.
We'll
I
just
just
call you Dr. AVG now. Okay,
I got
so
yeah.
whenever you're ready, you can just start reading the script and I'll just respond as a patient with every cue, okay?
Okay.
Go for it. You
You
just
can
have
read.
to read. You don't have to think about anything.
Okay, just I have to read whatever is there,
Put
right?
in your name. Yep.
Yeah. Okay. Hi, I'm Dr. Anu. Thanks for coming in today. Before we continue, sorry, I would like to start again. Hi, I'm Dr. Anu. Can I know your name and age?
Yeah, hi, I'm Larry and I'm 30 years old, Doc.
Oh, nice to meet you, Lab. Thanks for coming in today. Before we continue, I want you to know that everything we discuss is confidential. Is that all right?
Yep, that's all right.
Yeah. So I would like to ask you a few personal questions. I ask all my patients because they help me care for you safely. Is that all right?
Yep.
Yeah. So do you have any concerns at the moment?
Yeah. I'm it's a little bit uncomfortable, Doc. I don't know where to start.
You can share with me whatever you want to because it will be confidential between you and me anyway. So I'm it's totally all right.
You want to try reading it? Read the
Oh,
blue stuff.
oh, okay.
The blue stuff is all for you. I'm going to make my words, and the blue stuff
Put
is
your
for
mouse
you.
there so that pointer there so she can see where you are. The
Yeah,
way
Oh,
it
yeah.
shows. Put your
Mhm.
pointer there. Higher, higher. Yeah, there we are.
sure, yeah. I want you to know that many people feel embarrassed or concerned about speaking about certain things with their doctors, but I'm here to reassure you these are the kind of things we deal with every day.
Yeah, that sounds good, Doc. Thanks for that.
Yeah. So many people will experience symptoms like vaginal discharge and ask,
Yeah.
yeah.
So I've been having that, Doc. So, it's pretty common. No, I didn't know that. So, yeah, I've been having this. It's going on for a few days now, and I was a bit concerned because it's starting to smell now. So that's why I'm in here.
Oh, that's good that you just came into me and asking specific questions help me work out what's going on.
hmm Okay, you can skip the gender stuff because I'm female. Then you can go back to the next one.
Okay. So can you tell me the color of the discharge?
Just skip that for this tutorial. We're not going into basics of actual history taking, because that
Yeah,
would
are you in
take.
a relationship there? That one?
Yep,
Is that
yep,
okay?
this one.
From are you in a relationship?
Correct.
Yes, Doc.
Yeah. So are you in a relationship right now?
Yes, doctor.
One partner or more than one?
I did have more than one partners lately.
Okay. Can you tell me how many partners in the last 12 months?
About three.
Three. Okay. So are your partners male, female, or both?
All male, doctor.
All male. Okay. So
Okay.
yeah. So which type of sexual contact do you have?
Um, for example, like, what do you mean, doctor?
So what type of sex do you prefer? Is it oral, anal, or both?
Preference is normal, doctor. Both.
Okay. So do
Sorry,
you,
I didn't add vaginal. My bad. Go for it.
okay. So do
Next
you
one.
use
Um,
condoms?
Christine, 1 second. Do you have at that moment asked, are you the giver or the receiver?
Oh, not that one. Yeah, I should have added that one.
Okay.
That's a good one. Um,
Doc, are you giver or receiver? That means
both.
like
Okay, so
Both.
both.
if it meant, okay.
Okay, both.
hmm
Okay. Shall I
Do
continue?
you use condoms? Yep.
Yeah. So do you use condoms?
Not every time, doc.
Okay. Sometimes or never?
No. Sometimes I do, but not, yeah, every time.
Ever tested before for an STI?
Yes, a few years, doctor, and there was negative. I had only one partner back then.
Okay, all right. So could you be pregnant by any chance?
I don't know. I have not checked.
Okay. Do you use or need any contraception at the moment?
Maybe later, doctor. Yep.
Yeah. So any other symptoms like any ulcers, rash, or fever?
Yep. So all those things will be dependent on your cluster and what you find, okay? And then the last stuff about safety and stuff. So I hope the script itself, again, we will need to add and flex this as we go, and each thing will not work for everyone. As long as it sounds natural to you, I guess that's the whole point of it. Thank you so much, doctor, for volunteering for this one.
No
We'll just
worries.
move on to the next one. I guess another one that comes up quite frequently. Oh, oops. Is a travel counseling. So there's someone, male, particularly middle aged, who's kind of going into overseas for a trip, and they say Thailand or South Asia and stuff. And I think one of the key points of that station is also sexual health counseling and informing of the risks. So I guess that's another one. I am actually a bit slow on time, so probably we'll leave this to the end if we do have time. I've done the script here. Again, having a normalization for this conversation is going to help you. Because if you're going to ask directly, are you going alone? Who are you going with? You're kind of innuending what are you going to do for for this whole trip. Normalizing, a few ways to normalize it is people tend to have more sex on a holiday. Are you planning on having a lot of sex? Okay, is it with your partner? Is it with the locals? And what do you think? Are you going to be using condoms? Do you use drugs along with it? Have you considered the risk and those things involved? Do you want to get checked for STIs? And this is applicable for both when they come in or they go for a travel and they're coming in for advice for you. So this is generic. Again, weaving into the conversation is, I'm trying to say that these things will come up. Sexual well-being will come up across different kind of OSCE situations. Just be prepared to have phrases that's going to help you, and make sure you're kind of asking what's relevant for that particular STEM, and not kind of just asking vague questions. The stuff about this is to ask about locals firstly, and to ask vaccination, and asking about sex workers, and if the sex workers were transgender, because all those things will be different risk. Okay, so now the basics. This really helps, and this is something I've learned through counseling as well. First one is the ask tell ask approach, right? You do not go in a flow back to back, and do not speak for more than a minute without asking about feedback. So make it a point when you're talking to people, eye contact, whatever you're comfortable with, hand movements. But the most important thing, are you with me? Do you have any questions so far? Use these fillers between those sentences. And role players generally tend to let you talk. You do not want them to continue with that, because that doesn't look good for the examiner. Role player just really wants you to get all the information out. And they're doing this 30 times, right? In reality, your patients will ask you, and they'll have questions as you go. So giving them space and signposting things if they have questions is a really good approach. So you ask them, you add on to their knowledge by telling in things that's really help that you want like to add on, and then you ask again if they've understood everything. So this is the ask tell ask approach. And remember, this will only come through with acknowledging the knowledge in the room. If you believe that you're the best person in the room who has all the knowledge, this is not going to work out for you. So that's the unconscious bias that'll come out as well. So if you recognize that people actually might have more perspective into a condition than you, that's actually going to be helpful for you in counseling approach. The sandwich technique is something that you also need to use, because we tend to always add on to the bad news. Oh, I'm really sorry to tell you, but you have an STI, and this is what it's called, and this is the and I don't know how do you feel about it. Instead of that particular approach, the sandwich technique is good. Thank you for coming in today. And from what you said so far, I'm considering you might have a disease, have a condition called chlamydia or gonorrhea. What it is, it's a bug that is there and it spreads through sexual contact. However, we do have treatment and it's completely curable. So again, using the good, starting from the good, going to the bad news or the not so good news, and then going to the good news again. Acknowledge the emotions as soon as the emotions come up. So as soon as they say, "Oh no, I can see how this can be really hard, and this is not what you expected," acknowledge it. You don't have to kind of do anything about it, but you just acknowledge it. If you do not acknowledge it, oh, okay. You don't have to empathize with everything. You can just acknowledge it sometimes and name the emotion, and that's going to be more helpful in this particular counseling station where you're actually on a time crunch. And then you go for reassurance. It's completely treatable. I can understand how this must not be the news that you heard, but we will be helping you through every step, and we'll do follow-ups as well. You don't have to worry too much. So that's the acknowledge part. Explain it simply, because if you say chlamydia, gonorrhea, they're not going to remember the words most of the time in real life. So make sure you tell it's a bug that is there in your private parts, and that's going to help these things. If you do not treat it, I guess the most important thing is they'll come with dysuria, and they'll be like, oh, it's not really a bad thing. The complications, it's then going to help them understand, oh, I better treat it, right? Because most of the time you'll get asymptomatic STIs in your clinic. So it's really important to mention the complications. In terms of young people, I think it's important to be opportunistic, and using the word opportunistic. GP practices all across the Australasia, we get funding to be doing opportunistic STI and family planning sessions with people who are at high risk, especially the young people. So very important to kind of add this in and squeeze in how simple it is, because young people tend to not look after their well-being because of the urine and the lab and all those things, right? As we're doing the exam today, I can take some swabs, we can collect some urine, and then I can do a lab form for you as well, and we can start you with medications. If vaccination was not done, be opportunistic. While you're doing the bloods, we can do some vaccination as well if you're keen. Just throw in these words. It's really going to help you shine, because this is what happens in real life, right? So if you're going to do that, it's going to make sure you're looking natural, and this is what you do every day. Ease of treatment. you do not need to explain because injections are sometimes not perceived well. So with gonorrhea, it's going to be a bit tricky. So every time mention, it's just a simple injection. It's not going to be as painful. We'll monitor you. Everything you say that's going to be this uncomfortable, you reassure after that. So talk about those things. And never ever miss questions. That's where you will get the best marks, and that's where you will actually pass. So if you do not ask, leave space or room for questions or concerns, you won't get to address them. And that's where another pitfall of counseling happens. You're just talking about everything you know about gonorrhea, the treatment is blah, 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 blah. You not ask the questions about contact tracing. They will ask you questions like contact tracing. They will ask you questions like, can my partner have it? I don't want to tell them all those things. We'll come to that as well. But leave space for questions. Yeah, so this is the basics of counseling. You'll probably skip this. It'll be on that. This is just the general of counseling. Now with HIV counseling, it's a bit different. We're using the spikes approach for this one. You could read through it. It's a general spikes approach and a basic framework for it. Again, the same approach goes in. As soon as you see an emotion, you offer reassurance, sympathy. And you really have to show it. You just can't say it, okay? So do not use just words. You will have to display it as well with nonverbal cues. Yes, with silence, I think most people, when people start to cry or people get bad news in the role-playing situation, you sit with that discomfort and that silence. And that shows as incompetence for handling a situation. This is actually your make or break situation. So as soon as there's a pause and they're crying and you've done your thing, sitting and being comfortable with that pause and that silence is going to make the examiner know that this is what you do every day. You give space to people who need space. You're not just using time to kind of say. You're giving them time to process. So that pause is really going to use that pause, use it and shine with that pause. And then the role player themselves are going to tell you because they know about your time crunch. They're going to be like, oh, it's all right, doctor, you can go on. And then you use your cue. You use that cue, okay, to move on. Okay, now that you're okay, let's just talk about these things. I'll go slowly and I'll give you everything in a handout. Please let me know. So that was the HRV. And HRV counseling comes as in a pregnancy counseling. So make sure you're really, really sensitive because a pregnant lady is worried about the baby getting HRV. Okay, in terms of counseling extras, you have your contact tracing. So these are some things that you need to worry and actually talk about. Let them know, drama down below. These are for anonymous sexual health contact tracing and community nurse and family planning clinics. And this is recommended more for people who have recommended recurrent STIs, so they can be followed up properly. Support groups, especially when you're having young people and you think there's more support that's required with the rainbows or with the recurrent STIs or someone who's going through emotional challenges as well. It's really important to mention the support groups as well. So Talkline is a general sexual health kind of a helpline. You can ask all your questions and you can tell them, after you go home, you might have more questions, just call the Talkline. Rainbow Door is the one for the community, the rainbow community, and then you have Melbourne Sexual Health Center that gives all the advice and the STI guidelines. So remember, even if you're not in Melbourne, just remember the Melbourne stuff. The exam is in Melbourne, so you can't go wrong with that. And then you always end with red flags. If this gets worse, if this happens again, please come back. Follow up. Do not end a STI counseling session with, that's it. At the end of the session, I will see you next week or we'll see you in 2 weeks. Just make sure you blurt it out because this is not the end point. Your end point is when they are treated and they don't need your support anymore. If you do have time, just go on and talk about general prevention. You cannot go wrong with a public health problem by just talking about general prevention stuff. Coming into actual conditions also to be considering with sexual well-being. You might have your basic STEM presentations of, discharge and all those kind of things. I guess sometimes we forget about sexual health stuff when you're doing red eye. And this is where you'll have to squeeze it in within your 6-minute main history. And it gets hard if you're not comfortable with the 1 minute spiel of sexual well-being. I need to ask you some questions and it's sensitive about your sexual health. Are you okay with it? And that's where the spiel for this one comes. So if someone comes with conjunctivitis and you have to ask sexual history, you have to, because there's so many conditions there that's going to cause your red eye due to sexually transmitted infections. So you have meningitis, you have HIV, you have pear diseases, post-infection, post-gonococcal reaction. You have, where's the other one? Yep, these are the two, three that I can see right here. But the most important thing is you need a one quick spiel for these things as well. Same with the rash and sore throat. Young person, rash and sore throat, do not ever miss sexual health, because it could be HIV, it could be EBV, with the normal stuff, and it could also be your gonorrhea and chlamydia, which is spread through oropharyngeal gonorrhea and chlamydia. So make sure you have a 1 minute spiel for these.
I have two things to add there. One is that if they have a rash on the penis, always check if you have a rash in the mouth.
So
Second
that,
thing is that AMC is very fond of reactive arthritis, writer's syndrome. So you must ask if you have joint pain and uveitis.
yep. Yeah, so that pair syndrome really takes everything off. So reactive arthritis, the post-infectious arthritis, it's really, really common. And not just that, for knee pain as well. So again, remember, you're looking at a cluster when you're studying, and you're keeping this in mind so that it comes out in the exams naturally. So that was the pair stuff. So that was something to remember with. It's also with gastrointestinal. So you have genitourinary, which is your chlamydia, gonorrhea, but you have gastro like Campylobacter as well. So remember that stuff. Always remember uveitis, urethritis. This is all part of this whole cluster. So these are the parallel symptoms they're asking you to kind of think about when you're doing the history taking. So don't keep them on the back burner. Ask them in a flow so you're ticking those boxes. Yep, I think we covered this bit. I think now we'll go into the main. So when you're doing the management, right? You've done the counseling, you told them about that stuff. Now you're going to management. So in terms of investigations, do not forget your office test. You know, people usually go into the swabs directly. Do not forget your nitrites. It's going to help you immediately tell you if you have a UTI or not. And that's going to help you at least do first management today. The next one is UPT, because that for females, if you do not do a UPT today, that's a very big pitfall, because you will not be able to consider the antibiotics safe for pregnancy if you do not do a UPT. Now with swabs, that's the one which is going to be difficult. I guess you have to remember most of it. It's an easy thing. Like anything with discharge, you take a swab. Anything with an ulcer, you take a swab. Anything with a sore or a rash, you take a swab. In terms of other stuff like cervicitis and lower vaginal discharges, it's really important to take a self swab that's called a SOLV, SOLV. So self-obtained vaginal, SOVL, sorry, self-obtained vaginal lower vaginal swab, and then you have the clinician taken swab, which is your endocervical high vaginal swab. So make sure you're making endocervical swab super duper important with PID. Okay, so with anyone who comes in, you have to take it. I think one thing that I did not do here is PFI. I skipped it on purpose, but if you're doing PID, do not forget cervical motion tenderness. That's going to really help with that PID, honing on to that PID diagnosis. Coming back to this one, actually, labs. So we're doing urine as well. So you're doing culture of urine, and that's your NAT and culture. So do not miss culture just because you're doing NAT. NAT is the nucleic amplification PCR, and that's done with the first pass urine. So remember to say the first pass word with the NAT test. You can do it with any urine sample, but the first catch one is going to be the most helpful for diagnosis. With HIV, you give the warning 6 weeks, you're not going to be having a diagnosis. So that's when the last sexual contact will come in place. When was the last sexual contact, which was risk of HIV? And that would be 6 weeks. And Hep B and Hep C as well. So again, needle sharing comes in the background, then you come in with these two as well. With management, I put in this whole flow chart. You need to know a few kind of things, how many days and the grams, all those things are not required for AMC purposes, not too difficult. But I guess if you do not know this, then it becomes difficult to understand what other conditions can you get. From all these things, I think the ones that we forget to do is the syphilis, because these are kind of not the most commonly asked questions, so we don't know much about it. Syphilis one, there's different in terms of contact screening, so primary, secondary, tertiary. So remember about the 3 months. Penicillin allergies is an important question as well. Also, chancre, those things are really going to help you. It's very straightforward when you have a syphilis condition. With mycoplasma, this is something we don't anticipate because we think it's the same. It's not as important, but it is a very high cause of infection in FSF. So if you have females, it's really important to consider mycoplasma. Also, people with recurrent STIs to consider mycoplasma as something if you've not done that before, because mycoplasma in Australia is actually developing resistance to doxy. That's the reason it's important in AMC point of view, because if you're not thinking about mycoplasma, AMC clinicians are thinking you're not thinking about an important condition that's developing resistance. So very important. With monkeypox, again, with MSM, it's really important to take monkeypox PCR. Again, no treatment, vaccination, very helpful. Trichomonas, what's going to be helpful for you is to understand the cervicitis. So the strawberry cervix, the classic one, but even though if there's no strawberry cervix, having someone who is FSF, who is probably, had exposure to in contaminated water as well. So it spreads through water as well as sexual contact. Okay, so all the treatment is for partners as well. So everyone has contact tracing, everyone has partner treatment as well. So make sure you add that on when you're doing the management and you do the let them know kind of a thing. MSM. Now this one is important because these are different stations altogether. So we're looking at doxypep, which is a hot topic as well recently because it's so easily available. You just take 2 tablets in 2 days, within 3 days of having a high risk or high exposure to sexual activity. And this is really helpful for those parties that we are talking about. And yes, it does help with chlamydia, but mainly it is used for chlamydia, but it's also helping with syphilis. Every time we talk about PrEP and PEP, you also talk about, it's not going to prevent HIV. So with PEP, with doxy, also talk about HIV, and also with condoms, it's not going to be 100% preventive for HIV. So always mention that and put that disclaimer about HIV and bloodborne infections like hepatitis as well. Yes, this is a case that comes in also with diarrhea. So he's been on PEP for too long and now he's having diarrhea as antibiotic associated. So again, something to be mindful for. Doxypep, taking it for a long time, is he having diarrhea? Also to rule out with doxy, every time with doxy, you talk about esophagitis and give them a warning sign, sit straight, don't lie down as soon as you have doxycycline because it does cause significant esophagitis, nausea, vomiting. So always when you talk about medications, I think we always forget about the side effect stuff because we're not really prescribing it in the AMC. Signposted. Doesn't have to be too long, just really quick signpost.
Christine, there's a question. Yeah. AVG raised her hand.
Sorry? Yeah.
Someone raised their hand. What is the question, doctor?
Doc, whenever we counsel a patient regarding STI, so we have to mention about PrEP always or only in certain conditions like where we are suspecting HIV?
That's a really good question. The whole STI guideline has this whole information. The most important thing, the PEP. If you read the guidelines, it's not for someone who is not continuously following up with you. So someone who's just coming for a one-off consult, it's not suitable for them because you do have to monitor your LFT. Where did it go? You have to monitor your LFTs, you have to monitor for side effects, antibiotic resistance, associated diarrhea and all that. And also you have to continuously monitor for HIV because someone is doing high risk activity every weekend, you need to monitor for HIV as well. So really, really important. Those are not people suitable for PEP and PrEP. For a post-exposure, everyone gets it. So there's no kind of criteria. Anyone who feels like they've had a risk or there was an abuse or anything, you offer PEP. Would you like PEP? It's a pill we give you. There's double and triple therapy. We just give it to everyone. It'll reduce your risk. And then, you just give PEP to everyone.
Yes.
Time. It has to be within 72 hours of your protective sexual intercourse.
Yeah, the recent studies, so that's another one as well. Recent studies that could be given for longer, up to 1 week. Again, the efficiency will reduce, but 72 hours is the guideline. You have to offer it for within 72 hours. If they want to, they can take it for later as well. And again, you also can signpost it as, you don't have to decide now. I can give you a script and then you can think about it later. With PrEP, for example, there's this whole PrEP counseling. So really try to understand the basics of it is 2 hours before sexual activity, it needs to be taken. So if you don't know, then you can't take it. If it's more than 3 times that you need prep for HIV, then we just do it weekly. So there's no point of taking it like 3 days instead of 4 days. So just take it every day again. Monitoring LFTs, RFTs is super important with these medications. So not suitable for people who are not regular to follow up.
So it's like a first only one consultation, right, doctor, in AMC. So there we have to mention about the prep and we have to tell like it's on demand and there are like other things and we have to tell them that you have to come for follow-up, then only you can take for.
Correct. So read the room again. If there's someone with really high risk activity and you are doing a public health obligation here, remember that. You're doing PEP by doing a public health service. When you're offering PEP, you're reducing the incidence of chlamydia within the community. So just say it. It's not going to be a pitfall for you. So if you're seeing risk anywhere, just say.
Okay.
Don't worry too much.
Yeah. Thank you.
Don't overthink it. Yeah. And it's not a whole question, it's part of a question. So yeah, don't worry too much about it. But it's an important question that'll help you pass. So just keep in mind for that. And that's a doxypep spiel. It's on the website, so I'll just put it in here as well. We're kind of going down on time. Okay. Quickly doing this. So herpes, I think very important stuff with herpes and the questions that come around it. I guess one more thing with herpes that is a pitfall with students is I see when the patient asks questions like, oh, but I've not had any unprotected intercourse and I have only one partner. How am I having herpes and how am I having this? And this is a case of recurrent herpes. And that's where you have to kind of decrease stigma and discrimination and not directly say, is it my partner? And use neutral language. You know what? I'm not sure. It's really important. I take a swab today and I do some PCR testing to see what kind of, I do the serology. So that's going to help me understand whether it's a reactivation and, but at this point of time, there is treatment and I'll give it to you. So give a little bit information and go back to the topic. So reassure just a little bit. Investigation will help me and I'm going back to the topic. So do not just keep blurting out, it's probably the passion and go on another tangent over there. So that's something that's helpful with herpes. Remember to also consider other stuff like conjunctivitis and eye ulcers as well. If they are older, then consider Shingrix as well. Okay, I think we'll skip that stuff. This is from Talia O'Connor. That was I know people use a lot of color coding for rashes and stuff. It's not very helpful in my opinion, and please don't go by just the color of the discharges. It will kind of skew it will cause your own bias. So just go with thorough history and then you can use these things. But there is something within the history which is recurrence and purulent. So these two are really important stuff that you need to worry about, and how you come with your thought processes is going to help you pass. So it's not the question. Everyone knows what kind of infections are out there. How do you recognize and kind of hone into whether it's BV or was it PID is going to help the examiner pass you. So people commonly fail this station and they wonder why. Because you thought gray fishy is BV. And that's not it. So very important. These are the other things. And you need to say it out loud. You need to say, doxy would have treated chlamydia and mycoplasma. Cotrimox would have treated candida. We now have gonorrhea. It's unlikely because you don't have a fever. You don't have the other stuff going on. Metronidazole is a treatment that is going to help both chlamydia, trichomonas plus bacterial vaginosis. We'll do a trial of it if you're okay after I do some swabs. Then you talk about the other conditions that could have been were resistant mycoplasma or, desquamative inflammatory vaginitis. I think this particular word is going to make you pass by the examiner because it's a hot topic with STIs anyway. DIV, perimenopausal women, DIV is something that's really causing recurrent discharges. So make sure you're addressing that. Candida, some things there. Important thing with candida is to also ask the risk factors. Immunocompromised, diabetes, pregnancy, taking steroids, all those things are going to help you and get those extra marks for your candida. So everyone's going to ask about douching, but you're the one who's going to ask the immune stuff that's actually going to help you shine from other people. And lifestyle, don't forget about those things as well, because stress and all those things can actually impact the flora and fauna down below. Purulent discharge and PID, again, a commonly failed topic because you do not mention, actually see the real picture. The real picture is you could actually have someone with an abscess in their ovaries and cause permanent, you know, infertility for someone if you've not addressed their PID. So it's a really serious stuff and medical legally as well. So make sure you're being really thorough when you're suspecting PID. In fact, suspect all discharge as PID. That's the worst case scenario. So make sure you're going through all these things. There is this case where you don't know what infection, but it's profuse and it's foul smelling and you don't know what it is. It is PID, and you treat it as PID. You do the empiric antibiotics after your swabs. You send the bloods and you do a gynae follow-up urgently. So, and then you also refer to sexual health. So if you do not know, you still know a lot of stuff. So make sure you don't think about, oh, I need to find out if it's chlamydia or gonorrhea. You will not. That's not the key assessment. Assessment is your history, your symptomatology, and kind of making a plan that's going to be workable according to the therapeutic guidelines, right? So that's going to be helpful. So don't worry about what kind of condition, chlamydia, gonorrhea, which one it is. Because at the end of it, everyone just does swabs, everyone just does wait for empiric treatment and then does that. Okay, almost time here. Sorry, do you want to do a little bit more? 5 minutes? What do you think? I think this is the last slide.
Go ahead. Please go ahead.
Yes.
So, ovarian abscess, another thing that people skip adnexal masses with PID and this stuff, because you need to think about abscesses which are deep-seated, especially with low-grade fever and all that stuff. So make sure you're asking those things. Genital warts treatment is another important topic to cover, and history taking. The warts. Even and another question that can come in counseling was, oh, I did take the Gardasil, but I still got the wart. And then you inform them and psychoeducation. It's not just one. There's lots of types of warts that happen. We give the vaccination for the two most common ones.
This does come, and there's a big high failure rate for this particular case.
Yeah. And again, it comes back to not taking good history, because the wart history is not a sexual health history. It is a swelling history. So if you're not taking a good swelling history, this sexual health screening is out of the way. There's no point of learning all this. So today's was only talking about the normalization of these things. But again, your basics have to be really good for all that. I'll go to males. Where did that go? Did I do the male stuff already? Oh, this was the last one. Okay, so I have this stuff as well as a handout with these things. But really, really important to consider other parallels with this. So whenever you're doing private health, private body parts health stuff, make sure you're considering partners. Make sure you're considering the impact on quality. For example, the lichen case, right? Your person is itching continuously. How does this impact you? Asking that simple question is going to make you get more on your patient. The patient response, right? They give their rating for you, and that's going to help you understand, get better marks there. Do not forget the non-STI related stuff like cancers and vulval cancers, cervical cancers, Bartholin cyst. Bartholin abscess is actually a topic they ask you with the photograph, and it's really funny because this is also a high failure question, because people don't know the difference between cyst and abscess and how it looks like and how it presents. So make sure these things are really thorough for you when you actually have a look at these pictures, because it's going to help. Nabothian follicle has not come for a while, but that's another presentation within, when you're doing a PFE, you won't get anything. And then in the PFE, you'll be like, oh, there's some cyst there. And you're like, what is this kind of condition? This is coming with a PI, with a discharge. And that was a cyst that kind of breaks up every time there's intercourse. So that was your Nabothian follicle, not uncommon. And and it's a simple condition and very reassuring to the patient. So the non-sexually transmitted infection. So again, when you're going for these consults, don't assume everything is going to be a sexually transmitted infection. You just ask it as a basic question. Just be naive. It's going to help you. You're going to ask it very neutrally. Second thing is you're not showing any kind of biases or previous preconceptions, and you're asking it as a general screen. So you're curious about what could be the cause of this particular distress that the patient is having. And that's it. I know I rushed through a lot about these things. You'll have the slides.
The couple of the red flags people always need to know. One, if the woman is premenopausal, is a postcoital bleeding. That goes even menopausal or premenopausal, but postcoital bleeding is really important. Postmenopausal bleeding, if she has had a menopause for 12 months and if she's still having bleeding in between after that. These are the things you must ask because the examiner is waiting to see if you have actually seen the patient sitting in front of you and you are being a very safe doctor.
Yeah.
And when you don't ask questions, and majority of the doctors fail the AMC exam not because they are not clinically competent, because they are not seeing the patient who's sitting in front of you. You have this imaginary list and you are in a hurry to get it through. Don't
Yeah.
listen to the patient. Very important.
So don't have preconceived notions about a case. That's going to really blindside you because you're going to be in this tunnel and only you're in the tunnel. The examiner is not with you. So you're going to be in the tunnel asking about sexual health, and the examiner is just looking at what an incompetent doctor only talking about sexual health, not talking about menopause, not talking about bleeding, not talking about general screening. So do not have this notion about one particular issue. If you do a little bit of everything, that's going to be more helpful than doing everything thoroughly. So do the main stuff and do the stuff that's important first, and then you do the other stuff. You cannot focus and do 100% of one thing and then completely um, go downhill for the counseling part of it by just kind of and it's not going to help pass the station. So
And
just keep asking.
don't try to impress the examiner. They're not going to be impressed. They have a checklist and they're just going to mark that. There is
Impress
no
the patient.
impress the patient, be the best doctor. When you leave the room, your patients will say, "Oh, that is one of the best doctors I've ever seen in my life." Don't ever think of, "Oh, I'm going to show to the examiner that I'm good or I am this or I'm that." It won't work. Okay, there's one more question. What is it, doctor?
So, Doc, so what is the best approach to approach a patient like who is like young female, want to be sexually active for the first time if they're coming with that counseling? So, what's the best approach?
Best approach is neutral. You ask, okay, what would you like to know today? First, you ask the ideas and concerns, and then you go into because there's no actual symptomatology, so you have more time for concerns. What were your main concerns? So some things that really helped me understand ICE is what would make you think that today would be successful? What would help you? What would you like today to feel like this was a success? Was there something that's really worrying you? You read the person and you ask these questions accordingly. So you won't ask someone what's concerning you if they're looking happy, right?
Yeah.
So what would you like to know today that would be really helpful for you? What's something that's really important to you? Go for those kind of things. When you have someone with a discharge and they're looking a bit awkward, people kind of Google these things. Did you try to Google to find out what's going on? And would you like to share that maybe? Because if you're just asking, what do you think is going on with this discharge? And it's just for sticking the box of the ice, it's going to be very obvious. And like I said, you will only get this through practice. You will not get these words to use without practicing. So you think that I'll ask this question and it'll sound natural. It will not sound natural because you're not reading the patient. And that's where looking at the person and doing the role plays is going to be more helpful because now you're going to read. So that was the pitfall. So when you're asking about the young female, very important to be neutral, go in with everything and then come out with what would you like? Go out, follow the cues. Do not forget your screening stuff. Do not forget your prevention stuff. And then if it was FSF and all those kind of things, that actually is the case that comes through. With that one, okay, is it coercion? So something like that in terms of safety and risk you need to consider. And the next one is dental dams. Now everyone says dental dams, but nobody really tells you that they are very, very expensive. A condom is $10, and it's all about the whole masculinity and your patriarchy propaganda. But dental dams are like $40 for sexual intercourse, which is a daily thing. So really important to talk about DIY dental dams. And there's a whole video on how to make them using a condom on the sexual health website. So if you give this particular information in that situation, which is really practical, it's going to show the examiner you're doing this every day. Like I said, if you do not know and you just say dental dam is going to help and we use it every time and you don't know the backstory of the dental dam, it's going to sound like you really don't know $40, a young person, can they really afford that every time? And talking about
So
her.
I can help with the question. The way you need to answer the question is to wonder or think, why has AMC given me this particular case?
Yeah.
So what do you think AMC gave that case, like a young person wanting to know more about sexual intercourse? What are they looking for? There must be a reason, right? Every case that you're doing is to check certain domains, certain reasons. Why would they give you this? What would be the reason? What do you think?
So I feel that it's a common like at any young age people wants to know about more sexually active things and how to prevent
No, that's not why
how
they
we approach,
gave that. Anybody else want to answer?
maybe how we are approaching.
No, it's not a usual case. No. What is there? Prevent pregnancy? No.
This was
They're
abuse.
looking to see your prejudice.
Mm.
If
Mm,
you are culturally appropriate, you can give appropriate care to the patient. Or are you? So I know someone who actually failed a case like this because she said, in my country, no young girls can have sex. And no, 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 sex before 18 is bad for you. Don't. Or sex before 18, before you got married. No, you can't do that. So they're looking to see your prejudice.
yeah.
And so every case, when you stand outside, look and see why. Why have they given me this question? To see if you're safe to work here in Australia. Do you have prejudice that will probably not make you a safe doctor here?
Yeah,
That's why.
makes sense.
If you don't do anything and you just ask in a way patient feels comfortable, I think you'll still pass, because at the end of it, everyone can teach you STI guidelines, right? Those things are something that you can learn. But things that you can't learn is, that take a lot of time to learn, rather, is changing your beliefs and thoughts about some people and situations. So if you spend a lot of time thinking about these things, the so you'll actually handle gynae obs, you'll handle psych cases, and these things can help you throughout all your stations in general. So why not, right? Think about your own prejudices first before you think about it. Also, focus on the words. I do notice a lot of you do role plays with each other and you'll use the same exact words. For example, I'm a bit worried today. Everyone says the same exact thing. Oh, don't worry, these things are something, or everything is confidential. Everything is confidential. You use the same exact words 2 or 3 times, and what's confidentiality going to help me? I'm feeling worried. Like, it doesn't help me as a person feeling worried that you're telling about confidentiality. But my worries can come from my own misconceptions about diseases, or like it's taboo for me to talk about these things. So many things can cause worries, right? You just address it and you normalize it. That's going to really help across different things. And there's other things culturally you could do that you could think about upskilling in. Focus on yourself first. Focus on what you're not good at, and that's actually going to help you through these stations. And that will come with practice.
Recently, recently, when one of the doctors asked the patient, "Are you in a stable relationship?" The patient spent a minute asking, define what stable is. And because when the patient throws a curveball like that, you lose your momentum. Because all through your practice role plays you've done, you ask your other colleague and then ask, are you in a stable relationship? They'll say yes or no. But then when the patient asks you to define what is stable and then you don't know what it is, you've lost your momentum. So every time you ask question, you need to think. Like people have asked, is it planned or unplanned? Why? The pregnancy, is it planned or unplanned? What difference would it make? So if it is unplanned, and the woman says unplanned, but she's intending to carry the pregnancy to term, are you still not going to congratulate her? So could you ask her, are you happy with the outcome? So you got a pregnancy test done? Excellent. Are you happy with the outcome? She says yes, congratulate her.
I don't see that particularly as a bad thing. If they throw a curveball at you, this is your chance. You have thought about these biases about yourself. You know it might have sounded a bit biased, right? You know it could have been like, oh, it would have sounded like, what's stable, right? Oh, that's a really good question. Have these things in your whole communication toolbox. That's an amazing question. Stability could mean different for different people's. I should have been more focused? Is it you have one partner, two partners? Be ready with your answers. So sometimes in your stress you go into your default mode. Acknowledge that. Acknowledge you make mistakes. When they point out your mistakes, go back to, oh, this was my own bias
Okay.
acting out. Use
When they
it.
point out your mistake, immediately accept it, say
Move
sorry,
on.
and move on. It's
And you can
very
use it for a rapport building, and that's going to be so helpful for you. So if you use a curveball like this and you've dodged it, I think they'll be more confident on you that you're able to handle these things.
but be prepared for the curveball. That's really important. Mm. What is? I also wanted to talk about the judgment, the what Crystalline started the session with, the judgment bias, and that is something that I need you guys to be very aware of. So assume you have come from elsewhere and you waited 2 or 3 years to pay for the AMC exam because it gets sold out very quickly. So you finally got a spot after 3 years and you have spent $4,000 for the exam, $5,000 for your airfare, and $1,000 for your accommodation. So your total cost now is $10,000. You're walking into AMC Center, your first patient is there, you're walking in and you're ready because you have to pass this exam because there's too much money involved. And you're walking in and you're going to talk to the patient and say, "Hi, my name is Dr. Verghese. Could I confirm your name and date of birth?" And she would go, "My name is Karen." And now, what would be the expression on the doctor's face? Someone who spent $10,000 to come here to do this, ready to get through this exam and pass the exam, and too much of money invested. Time is important. I have 5 minutes to get the history. What exactly would be the expression on the doctor? And what would be the thought process? My goodness, look at this AMC. Of all the patients available, they have given me an old patient who can't even speak properly. Correct? What do you think, AMC? So the thing you should have thought in that exact second is, why has AMC given me a patient who is talking slow? Every case has a reason. And you have actually, if in that split second where your face looked angry or upset, yes, testing, yes, patience and response, you're right, but there's something more important. Can you tell me why AMC would have given a patient who is
This is
talking?
older people bias. This is very common.
What is
Uh,
the bias they're looking for? There is something. Older people bias. Yes, empathy. Yes, keep going.
Elderly,
Patience. Yeah?
they're checking like our approach towards an elderly who is slow,
Yes.
geriatric.
Australian population is aging. Our people are growing old. And as an international medical graduate, you will be placed in area of need. There are elderly people there. You probably are the only doctor there. You don't want this patient not to come back to the clinic ever again because you have treated them so badly. So my mother was 82 and she was diagnosed with Parkinson's. She was staying with me here in Australia and I would have to take her to the GP. And when I took her there, my mother was treated like a queen. And the GP would only have 3 questions for her. And mom was so happy. So what you were meant to do in a station when the patient is going slow is not to get agitated, but to understand that a station has been given for a reason. It is checking to see if you understand. And if you can modify your response very quickly and be kind, you can see all of those responses after the exam. My God, they gave me an old patient and she was so slow. And I think, oh my goodness, don't you see? They have given you a case for a reason. And you fell into its hook, line, and sinker. So
so
careful with
important
your
when you're
bias.
anxious. When you're anxious, it will easily come up. So when your own thoughts are out and feelings are out of place, these things will really be highlighted. And that's the reason you do this as a practice, because if you do it on the last day thinking, I won't be judgmental, I won't ever say these things, and then you have these frustrations and microaggressions, we call them in healthcare. When you have these microaggressions, the examiners are trained to pick them up. Unconscious bias, microaggressions. And what you do is you'll get frustrated and you'll be like, oh, okay, yeah. And then you would change the tone, and that's the easiest way they can see it. and you're actually in your head, you're battling your own thoughts and feelings while you have shown on your face what's actually going on in your mind. So be very, very careful of these things. And again, if you don't do face-to-face role plays, even if it's virtual, doesn't matter. You do not know how to respond to. You will go in a script format, and that would be your pitfall for these things.
And you only have one chance to get through the exam. Remember, every mistake that you make, you will tank your station, and you don't want to do that. This is a very expensive exam. And it's a very doable exam. That is what hurts the most. There is no magic formulas. It's not hard. So long as you're a very safe doctor, you will pass the exam. The demand is very, very low for what expected out of you. But you guys spend so much time rote learning, and that can actually be seen in the exam. I can easily tell you which course you took by 10 minutes of a session with you because you use the same words. So imagine if I can tell that the examiner who's sitting there going through 38 doctors in one single day, they also pick all this. Don't rot learn. Be the doctor. You're very clinically competent. Each and every one of you passed medicine in your respective countries. You have the competence. Show AMC your competence. Don't rot learn. Anything else you want to add, Christine? Sorry, I hijacked your
No, it's
talk.
almost time. No. This was really practical. Again, like we said, I've not covered everything. I've just covered the biases that we might have mainly. That was the highlight for today. And the other stuff, you will learn as you go, and I'll put them in that you can read and understand. But just practice these things. And firstly, if nothing, and you've only been aware of what your issues are with these things, that would be the best part of today. So thank you for joining in and for your time. And thank you, Dr. Vinu. I hope this was helpful. And I will send these things to you, doctor, and you can just forward them to with the Word document, and you can send this to the candidates. And really, all the best. Keep practicing and be aware, and that awareness is going to take you everywhere. So just be prepared and aware, and that will not allow you to go into your autopilot. That just being there in that moment will not allow you to go into your anxiety attack. So just go with the flow with these things.
Thanks,
It's
Dr.
10:51 for Chrislyn. I don't want to keep her too long. Thank you very much for doing this, Chrislyn. I love you very much. You're awesome.
Thank you. Thank you.
Any
I
questions
wouldn't
for
have done it for
anybody else?
anyone else, so thank you. Awesome.
Thank you, guys. Good
Have a
night.
good night.
Good night.
Thank you. Okay, and if you guys have any questions for me, I'm happy to answer. Chrislyn, you can go to bed. Good night. Anybody has any question, anything for preparation that you need to know? I'm here. Anything at all? Or you guys all slept off? How many sleeping people? 11?
Thanks, Dr.
Thank you, Angel. All right, anything you want me to help you? So my name is Vinu. I run Oyamed, and I teach international medical graduates to pass the Australian Medical Council examination. So the difference would be that I am an OSCE examiner, not for MC. I'm an OSCE examiner for universities. So I sit on the other side and I watch people how they do the cases. And so I understand the mistakes most people make, and I try to help doctors to pass the exam. And you will find me on my Telegram or my website. You can always contact me. So is there anything else, any question that you have about the OSCEs? Anything at all? No? All right, then I shall close the session. Enjoy your evening and take care of yourself. Good luck with your MC preparation. Bye, doctors.
Thank you, doctor.
Stop recording.